picture this. It's 3 a.m. You are an emergency medicine doctor or highly trained advanced clinical practitioner standing right in the middle of a chaotic NHS emergency department.
Oh, we've all been there.
Right. The monitors are constantly beeping, there's a queue out the door, and you've just been handed the notes for your next patient. Let's call her Sarah. She's 26 years old and 2 weeks postpartum after a prolonged forceps delivery.
Okay. High risk already.
Exactly. And right now, her symptoms are frustratingly vague. She's complaining of profound fatigue, she is a little irritable with her partner, and maybe she's showing some subtle, hard-to-pin-down confusion.
Yeah.
So, looking at her from the end of the bed, you really have to ask yourself a critical question. Is this just the absolute bone-deep exhaustion of a new parent who hasn't slept in a fortnight? Or are you looking at a patient on the precipice of a life-threatening crisis?
It is arguably one of the most stressful clinical presentations you can face on a shift. I mean, the physiological overlap between the normal, brutal aftermath of pregnancy and the early stages of a catastrophic systemic infection is, well, it's incredibly deceptive.
It really is.
You're dealing with a patient whose entire cardiovascular and immune system has been radically altered, meaning the standard alarms we rely on in the ED might not actually ring until it is far too late.
Which is why today's deep dive is designed as an essential executive briefing for you on the front lines. We are pulling our insights directly from the newly published November 2025 NICE Guideline NG25B5. That's the one on suspected sepsis in pregnant or recently pregnant people.
It's a vital update.
It is. Our mission today is to cut through the noise and provide a comprehensive, objective, and incisive breakdown of these updated criteria. We're going to map out exactly how to spot, stratify, and manage maternal sepsis, detailing the clinically relevant physiological shifts, the specific risk stratification tables, and the exact fluid resuscitation protocols that have just been updated.
Because applying standard adult sepsis guidelines to this specific population creates dangerous clinical blind spots. My goal as we navigate this source material is to help break down these updated clinical pathways. We need to look at the likelihoods of various presentations and, most importantly, highlight the physiological traps that are waiting for you when assessing these highly vulnerable patients.
Okay, let's unpack this. We need to establish a firm perimeter around who falls into this high-risk category. When the NICE guidelines refer to recently pregnant, we aren't just talking about the immediate postpartum period, are we?
No, not at all. The time frame is very clearly defined. Recently pregnant applies to a patient within 24 hours of a termination of pregnancy or a miscarriage, or up to 4 weeks after giving birth.
4 weeks, so a whole month.
Right. But there's a vital clinical caveat built into the text regarding second or third trimester losses or terminations. In those scenarios, your clinical judgment overrides the strict timeline.
Because the body hasn't bounced back.
Exactly. A woman's physiology doesn't just snap back to baseline the moment a pregnancy ends. It takes significant time for that systemic vascular resistance, the cardiac output, and the immune modulation to reset to pre-pregnancy levels.
And even within that defined population, there are layers of vulnerability that should instantly lower your threshold for suspecting sepsis. If we look back at our hypothetical patient, Sarah, she had a forceps delivery. That invasive procedure is a major situational risk factor.
It's a huge red flag.
The guidelines also flag patients with diabetes or gestational diabetes, those who have had a cesarean section, or anyone who required the removal of retained products of conception. We also need to be on high alert for a history of prolonged rupture of membranes, continued vaginal bleeding, or an offensive discharge.
Yeah, those are the local infection risks.
Plus, there's a very specific situational flag regarding recent close contact with people with group A streptococcal infections, like scarlet fever.
Those are the direct clinical risks, yes. But the text also shines a really harsh spotlight on systemic vulnerabilities and health inequalities. The risk of sepsis going unrecognized skyrockets in certain demographics.
Which demographics are highlighted?
We need a heightened state of vigilance when assessing patients from ethnic minority backgrounds, those living in deprived areas, or individuals experiencing homelessness. The guidelines also stress how communication barriers fatally delay diagnosis. If a patient requires an interpreter, you are already behind the curve.
That makes sense.
Furthermore, for patients with cognitive impairments or learning disabilities, a dangerous drop in cerebral perfusion might not look like classic delirium. It might simply present as irritability or a refusal to cooperate.
That brings up a massive assessment trap outlined in the text, the repeated presentation. Let's say Sarah's partner mentions they actually went to their GP yesterday because she just felt off, but they were sent home to rest. As an ED clinician, a prior presentation with similar nonspecific symptoms is a massive red flag, isn't it?
It changes the entire risk profile. The early symptoms of sepsis, mild lethargy, a low-grade ache, feeling generally unwell, they're notoriously nonspecific and easily attributed to postpartum recovery.
Sure, just the tiredness of having a newborn.
Exactly. But if a patient is returning to the healthcare system multiple times, the disease process has had more time to evolve. Those nonspecific signs were likely missed the first time around, meaning you're dealing with a much sicker patient than their outward appearance might suggest.
Let's transition to the bedside. I want to structure our clinical assessment using the standard A, B, C, D, E approach: airway, breathing, circulation, disability, exposure. We need to do this because pregnancy completely warps the baseline for these vital signs. Let's start with exposure and temperature, because there is a persistent myth that a fever is a required ticket for a sepsis diagnosis.
NICE has drawn a hard line here. Do not rely on fever or hypothermia alone to rule sepsis in or out. It is a fundamental physiological error.
Why is that?
Because certain groups of patients lack the ability to mount a fever response at all. The guidelines explicitly highlight people who are already severely ill with sepsis, those undergoing cancer treatment, people with complex care needs, and importantly, patients with spinal cord injuries.
So they might be normothermic, but critically ill.
Exactly. And on the flip side, a slight rise in temperature might just be a standard physiological stress response following the trauma of childbirth. The thermometer is a tool, not a diagnostic oracle.
Moving to circulation. This is where we hit the most clinically relevant physiological trap of the entire deep dive: the baseline heart rate shift. If I'm looking at Sarah's monitor and her heart rate is 110, a standard adult early warning score might just flag that as a mild tachycardia. But what is the explicit baseline adjustment the guidelines mandate we make?
You must consciously adjust your expectations upward. The baseline heart rate in a pregnant or recently pregnant patient is naturally 10 to 15 beats per minute higher than their normal pre-pregnancy state.
10 to 15 beats higher. Just a rest.
Just at rest. This happens because their vascular tone is naturally dilated and their cardiac output is working at maximum capacity to support the physiological changes of pregnancy.
Which means they don't have the physiological reserve to compensate for early shock.
Exactly the issue. By the time that heart rate climbs over 130, they aren't just starting to get sick, they are rapidly falling off the cliff. A heart rate of 105 in a postpartum patient whose normal baseline is 80 represents a massive pathological cardiovascular shift. You cannot trust standard adult early warning scores to catch this. You have to interpret the numbers through the lens of obstetric physiology.
Let's look at breathing, specifically oxygen saturation. The guidelines pull in a very specific and critical NHS England patient safety alert regarding pulse oximetry. It turns out the tech on our fingertips isn't as objective as we like to think.
The safety alert highlights a known systemic flaw in pulse oximeter technology. These devices can overestimate oxygen saturation levels, particularly when the true saturation is hovering in that borderline 90 to 92% range.
And who is most at risk for this misreading?
The crucial detail for the clinician is that this overestimation is frequently reported in people with dark skin. The algorithms in many of these devices were historically calibrated on lighter skin tones, meaning the light absorption calculations can mask true hidden hypoxia in dark-skinned patients.
So your monitor might show an SpO2 of 95%, suggesting Sarah's respiratory function is stable, when in reality her tissues are starving for oxygen.
Yes.
And the text notes that if you are struggling to get a peripheral oxygen saturation reading at all, you shouldn't just assume the probe is broken or the patient's hands are cold. That poor trace might actually be an indicator of profound peripheral shutdown due to underlying shock.
Precisely. Now, let's cover disability or mental state. When you're doing your AVPU check or calculating a Glasgow Coma scale, it's not just about getting a score for the chart. It's about comparing that score to reality.
Right, because if Sarah is slightly drowsy, is that the sepsis talking, or is it the fact she's a new mother at 3 a.m.? The guidelines stress that your objective assessment must be paired with subjective context. You have to rely on the history from the family or carers who know what the patient's normal baseline looks like.
If her partner says she's not usually this out of it, you treat that as a highly significant neurological change.
Now we need to synthesize all of these clinical cues. This brings us to the core mechanism of the NC Guideline Table 1.
Table 1 is everything here.
It's the ultimate tool for stratifying risk into high, moderate to high, and low categories, specifically for pregnant and recently pregnant individuals. We aren't going to just read a list of numbers. We need to look at the phenotypes of shock. Let's start with the high-risk criteria, the red flags. If a patient meets even one of these parameters, they are in immediate life-threatening danger. What does the respiratory phenotype of a high-risk patient look like?
A high-risk respiratory presentation is essentially the body screaming for oxygen delivery. It is defined as a respiratory rate of 25 breaths per minute or more, or a new requirement of 40% FiO2 or more just to maintain an oxygen saturation above 92%.
Cardiovascular collapse is equally stark, isn't it?
It is. For blood pressure, a red flag is a systolic reading of 90 mmHg or less, or a sudden drop of more than 40 mmHg below their known normal baseline.
That relative drop is crucial.
Absolutely crucial. If they normally sit at 140, a drop to 95 is a catastrophic failure of vascular tone, even if it hasn't hit that absolute 90 threshold yet. And for heart rate, anything over 130 beats per minute is high risk.
And we also have to look at end organ perfusion, specifically the kidneys and the skin.
Renal shutdown is a major indicator. Not passing urine in the previous 18 hours is a high-risk criterion. If the patient is catheterized, that equates to passing less than 0.5 milliliters per kilogram of urine per hour. Finally, for the skin, you are looking for evidence of profound microvascular failure. That means a mottled or ashen appearance, cyanosis of the skin, lips, or tongue, or a non-blanching petechial or purpuric rash.
Those are the red flags. But the guidelines also define amber flags, the moderate to high-risk criteria. This is where a lot of patients, like our hypothetical Sarah, might initially land. The numbers are less extreme, but the patient is still incredibly vulnerable. What does the subtle slide into moderate risk look like?
In the history, an amber flag would be a report from a relative of a new altered mental state, a history of an impaired immune system, or having undergone trauma, surgery, or an invasive procedure within the last 6 weeks.
What about the vital signs?
Respiratory-wise, it's an elevated rate of 21 to 24 breaths per minute. Cardiovascularly, we are looking at a systolic blood pressure of 91 to 100 mmHg, or a heart rate between 100 and 130 beats per minute, or any new onset arrhythmia.
For hydration, it's not passing urine in the past 12 to 18 hours. The moderate criteria also bring temperature back into the mix, but specifically a tympanic temperature of less than 36 degrees Celsius. We also need to look for local signs of infection at a surgical site, redness, swelling, or wound breakdown.
What's fascinating here is how the guidelines manage the border between moderate and high risk. Let's say Sarah is tachycardic at 115 and her systolic blood pressure is 95. She meets the moderate to high criteria. But treating the vital signs isn't enough. We need to look at cellular metabolism.
Which brings us to the lactate tiebreaker. If Sarah falls into that moderate risk category, she needs a clinician review and blood tests within 1 hour. But if you draw those venous bloods and her lactate comes back greater than 2 millimol, or if her blood show evidence of an acute kidney injury, the entire pathway shifts instantly.
That is the critical pivot point. A lactate over 2 indicates that her tissues are already hypoperfused and switching to anaerobic metabolism. At that moment, you immediately stop treating her as a moderate risk patient and escalate her directly into the high-risk pathway.
So let's talk about that escalation. If the patient hits just one high-risk red flag, or their lactate pushes them into the high-risk category, the clock starts ticking loudly. We enter the 1-hour high-risk bundle. What are the immediate non-negotiable actions?
First, they require an immediate assessment by a senior clinical decision-maker. The guidelines do not leave this vague. For pregnant or recently pregnant patients aged 18 and over, this must be an obstetrician of grade ST3 or above, or an equivalent senior doctor.
And for pediatric patients?
If the patient is under 18, it requires an ST4 or above. Simultaneously, you are sending a comprehensive venous blood panel gas, including glucose and lactate, blood cultures, full blood count, CRP, urea and electrolytes, creatinine, liver function tests, and a clotting screen. And you must administer broad-spectrum antimicrobials within that first hour.
Let's focus on fluid resuscitation, because this is an area that frequently trips people up. The volumes and rates are very different from standard adult sepsis protocols, and they depend entirely on the patient's age. If we need to give Sarah, who is 26, a fluid bolus, what does NICE mandate?
For patients aged 16 and over, you use a crystalloid containing sodium in the range of 130 to 154 millimolars. The specific bolus volume is 500 milliliters, and it must be delivered over less than 15 minutes.
Less than 15 minutes, that's fast.
Very fast. And there is a very practical warning embedded in the text here regarding equipment. If you are using an IV pump to deliver this bolus, you must ensure the device can actually push fluid at the required rate, which means the pump must be capable of delivering at least 2,000 milliliters per hour.
That is a massive flow rate that some older ward pumps simply cannot handle. Now, what if our patient was under 16?
The protocol completely changes for the pediatric, pregnant, or recently pregnant patient. You switch to glucose-free crystalloids, still with sodium between 130 to 154 millimoliter, but the bolus becomes weight-based. 10 milliliters per kilogram delivered over less than 10 minutes.
And the decision to pull the trigger on those fluids is heavily governed by the lactate levels we discussed earlier. The guidelines lay out a clear, three-tiered logic tree for fluid administration based on that blood gas result.
The logic is driven by the severity of the hypoperfusion. Tier 1, if the lactate is over 4 millimol, or the systolic blood pressure is 90 mmHg or less, you give the intravenous fluid bolus immediately. But, crucially, you do not stop there.
You escalate.
Yes, you must simultaneously refer them to a critical care specialist to review the immediate need for central venous access and the initiation of inotropes or vasopressors. Their vascular tank is empty and the tone is gone.
Tier 2, what if the lactate is slightly lower, between 2 and 4 millimol?
You still give the intravenous fluid bolus immediately within that 1-hour window, as they are actively slipping into shock.
And Tier 3, if the lactate is below 2 millimol?
The wording shifts carefully here. If the lactate is below 2, the guidelines state you should consider giving a fluid bolus. You must weigh the risk of under-resuscitation against the risk of fluid overload, especially in a postpartum patient whose fluid balance is already highly complex.
If you give the first bolus and the patient isn't responding, meaning the tachycardia is worsening, the blood pressure continues to drop, or the lactate is rising, what is the next step?
You reassess and can administer a second bolus. However, if there is still no improvement after that second bolus, the guidelines mandate that a consultant must be alerted to attend the patient in person. You have exhausted the initial stabilization protocol.
But treating the numbers, pushing fluids to fix the blood pressure, giving antibiotics to fight the bacteria, monitoring the lactate is only half the battle. We have to talk about source control. You can aggressively resuscitate a patient for hours, but if there is an undrained abscess or retained products of conception, they are not going to survive.
Source control is paramount. You must tailor your investigations to the clinical history. The guidelines recommend a baseline urine analysis and a chest x-ray to hunt for a source in all people with suspected sepsis. If your clinical examination and initial tests leave the source hidden, you must escalate to imaging of the abdomen and pelvis.
And once you find it,
if the source is amenable to surgical or radiological intervention, you cannot wait. You must involve the obstetrician and the relevant surgical or radiological team immediately. They need to seek senior advice on timing and execute the intervention as soon as possible. Source control is not an elective procedure in sepsis.
Finally, let's talk about the human element. Let's assume the interventions worked. Sarah is stabilizing, the source is controlled, and she is moving toward discharge. The guidelines are exceptionally strict about how we manage communication during this vulnerable phase. It is not just about handing over a prescription and waving goodbye.
The medical, legal, and ethical instructions here are non-negotiable. Information must be provided clearly without hiding behind medical jargon. When discharging a patient who has been treated for sepsis, they and their family must be explicitly informed that they had sepsis. You cannot vaguely describe it as a bad infection or a complication from the birth. Furthermore, the discharge notification sent to their general practitioner must explicitly state the diagnosis of sepsis.
We also have a duty to provide robust safety netting. Patients need both written and verbal instructions detailing the specific warning signs to monitor and exact instructions on how to access urgent medical attention if they begin to deteriorate again. And there is an often overlooked legal requirement mentioned in the text regarding the people looking after the patient, isn't there?
There is. You must advise carers that they have a legal right to a carer's assessment of their needs. You are obligated to provide them with the information on how to access that assessment, and you should point the family toward national charities and support groups for sepsis survivors. The trauma of sepsis extends far beyond the physical infection.
So let's distill this executive briefing down to the absolute vital takeaways for your next shift in the ED. First, respect the physiological disguise of pregnancy. You must explicitly adjust your baseline heart rate expectations up by 10 to 15 beats per minute, recognizing that a rate of 110 might be a sign of profound shock. Second, be hyper-aware of the pulse oximetry pitfalls, understanding the algorithmic bias that can mask true hypoxia in patients with dark skin. Third, apply Table 1 with precision. Use that 1-hour bundle for any high-risk red flags, let the lactate drive your escalation from moderate to high risk, and remember the strict differences in fluid bolus volumes, 500 milliliters over less than 15 minutes for adults, ensuring your pumps can handle 2,000 milliliters an hour.
I want to leave you with a final thought to mull over as you walk into the department. We spent this deep dive analyzing how the physiological adaptations of pregnancy, the naturally higher heart rate, the maxed out cardiac output, the shifts in vascular tone so perfectly and dangerously mask the early clinical signs of a life-threatening infection.
It's a terrifying overlap.
It raises an important, deeply profound question. Does this suggest an evolutionary trade-off? By adapting the body so drastically to carry and tolerate a fetus, are we inherently suppressing the very alarm bells that keep the mother safe from systemic infection? And if that is true, how many other standard medical baselines are we using in the ED today that are actually blinding us to subtle life-threatening shifts in other uniquely adapted patient populations?
A brilliant and sobering question to end on. Thank you for joining us for this deep dive into the updated NICE guidelines. We hope you can carry these insights, in the case of patients like Sarah, directly onto your next shift in the emergency department. Stay vigilant out there.